I've had the privilege of working with ASCRS for many years. They've helped to devise quite a few interesting instruments, and mostly for lamellar surgery, also a bit for refractive and for SMILE. But I think the instruments that we have transformed how we perform DALK and DSAEK. And over the years, I've been very grateful for ASCRS helping us to make some of the very nice instruments. Just check, does everybody here do DSAEK? DSAEK? No? Not everybody? Okay, not yet. Anybody doing DMEK? Okay, so my talk today is to focus mostly on DMEK, but also on DSAEK, and really how to perform DMEK when you become a competent DSAEK surgeon, how to then change to doing DMEK, okay? These are my financial disclosures. You can see that I get nothing from ASCRS here. ASCRS is not there. So I have no financial gain, okay? Okay, so for those who are aware of the EBAA report, the latest report, you'll see that DSAEK, 50% of all transplants in the US. And you can see on the top right here that although it's 50%, it's not increasing. Okay, PK is on the left here. And if you look at DMEK, this is DMEK on a rise. But if you look at the actual percentage, these are in hundreds, these are in thousands. So really, we're talking about 6% of surgery is DMEK. Now, maybe it's gone up to about 8% now, I'm not sure, but it's still a minority, okay? In Singapore, we started lamellar surgery way back when we started the program back in 1991. In gray here are all PKs. These are the number of transplants each year. And you'll see that we started off with doing very little anterior lamellar keratoplasty. But really it was around 2000 when we did a lot more in green. And then we started our DSAEK program in 2005, 2006. Light blue here, we're beginning to do some DMEK. So DSAEK is still our most common operation now, 56%. That was last year. DALK takes up about 27%. PK is only relegated to 15%. These are the full thickness, very severe cases where you can't do a DALK or a DSAEK. And DMEK last year was 2%. Now it's a bit higher, okay? But basically what we're really looking at is the fact that 85% of our transplants at the Singapore National Eye Centre are now lamellar. And I think this is the trend. This is our history of adopting DSAEK. So we look at the cell loss. And over the years, we've been charting our cell loss, endothelial counts at 1 year. These are all 1 year figures. And you'll see that we started off with PK. Our 1 year endothelial cell loss in our PK eyes is 40%. In 2006, we started DSAEK using the taco folding technique that was taught originally by Garrett Mellers, Frank Price, and Mark Terry, and it's still a very common way of inserting the donor. We have Asian eyes, and our Asian eyes with high vitreous pressure, we were getting much higher cell loss. So our cell loss rates were 60% at 1 year, which was unacceptable. We then changed to the using a anterior chamber IOL sheets glide to pull through the donor, and we used this for a while, but straight away you see that we cut the cell loss down to about 30%. That was in 2007. And then we decided to invent a dedicated donor inserter, and that's the EndoGlide, which is made by Network Medical, and the cell loss dropped down dramatically to about 15%. So in the last 10 years, we have been able to basically halve our endothelial cell loss from PK to DSAEK, and then we get better and better. Now comes DMEK. The learning curve, I will show you, can be as low as 28%, can be as high as 59%. So this is the challenge of DMEK. It's more difficult to do, and you're going to get more endothelial cell loss. Okay, so you come back, they're not far off PK now. So we have to have something better. Which one do you do, DSAEK or DMEK? So here's one of my patients. The right eye had a DSAEK, he gets 6/9 or 20/30 vision. On the left, he gets 6/6 vision with the DMEK. If you ask him, he's 49 years old, he much prefers, he has Fuchs dystrophy, He much prefers the left eye because he gets 6/6 vision. However, he knows that his cell loss in the DMEK eye, he's only have 1,400 cells compared to his DSAEK eye, which has got double, 2,700. So which does he prefer? He's not sure. Okay, so this is the penalty. If you look at endothelial cell loss, this we published some time ago looking at all the various DSAEK insertion techniques over the first year. This is percentage endothelial cell loss on the y-axis. And you'll see that it ranges all the way from 60% down to about 12 to 15%. And these are all the different inserters, taco folding technique, the Busin glide, the endoglide is here in green, so endoglide has got the lowest cell loss. How does this compare to PK? I told you that our 1-year survival in the Singapore corneal transplant study for PK is 40%, so it's here. So endoglide is much better. But if you look at the cornea donor study cell loss at 1 year, this is the multi-center study in the US, they only have 22.8% cell loss. So even today, DSAEK may not be as good as PK. What about DMEK? Well, the main people who've been doing DMEK are Garrett Mellis, Frank Price, Mark Terry. They've done the longest now, reaching 5 years. And their results are there. So that is the same as TACO with DSAEK, about 30 to 40% cell loss. So unfortunately, we're back to this sort of level. We've got to bring it down to this sort of level. You can see Mellis, 34%, Price 36%, Cruz 39% at 6 months. Okay? This is 5-year follow-up of endothelial cell density. This is Price's, Frank Price, 5-year DSAEK study, where you see an initial drop, and then it stabilizes to about 55% at 5 years. Okay? This is where we are now with the endoglide. There are now 9 published studies, and the overall cell loss is much better. This is with DSAEK endoglide, probably the best results. Where does DMEK come in? It's still there. Okay? So it has to get a bit better. What about the Australian Corneograph Registry? Some of you will have read this paper, which was quite shocking because Australian Corneograph Registry has 22,000 graphs. They track everything in Australia, longest database, and they showed that lamella surgery is worse in their hands. So both EK and DALK have poorer graft survival. Here is PK, Kaplan-Meier survival for Fuchs. Here is EK. It's far worse. Here is PK, and here is DALK, mostly keratoconus. You see DALK is worse. And even when they split up DSAEK versus DSEK, DSAEK, and DMEK, DMEK does the worst. So this demonstrates a real-world situation where we have a lot of surgeons trying to adopt new techniques, and the results, initially at least, are not as good. This is the learning curve. So this is the problem with lamella surgery, both with DALK and with DSAEK and DMEK. You've got to get the technique right, and then you start to get better results than PK. This, though, the next slide I'm going to show you is the main problem with DMEK. This is the surgery. You've probably seen all of this. From Frank Price, Mark Terry. What sort of surgery is this? You've got to unscroll it, you've got to tap it, you can't touch it. Sometimes it takes 5 minutes, sometimes it takes 1 hour. And this is, Frank Price says, this is the fun part of surgery. Mark Terry calls this Descemet's dance. The concept from Mellis is supreme. Very nice, where you can see that the idea is good, but it's caveman surgery. What instruments do we have? We have air, BSS, and a BSS cannula. That's it. Okay, so that's all you're using there. Look at that. Go on and on and on. These are good videos, by the way. You think everyone, all corneal surgeons can do this? I'm not sure. There has to be a better way. Okay, this is just too primitive. We know there is a higher complication rate with DMEK. The graft failure can be as high as 20%. Higher endothelial cell loss as high as 40%. Donor dislocation, where you have to rebubble, could be as high as 60%. What's more important, the extra line of visual acuity or the extra 1,000 endothelial cells that you've lost with DMEK? There is a major advantage. We now think that DMEK has very low rejection risks. PK rejection is about 15%. DSAEK, 2 to 4%. DMEK, 1%. So there is a huge advantage in DMEK. And that's why, with this sort of surgery, the adoption rate is only 6%, even in the US. Okay, so this is the current technique. This is donor stripping. So there are two problems. One is how to prepare the donor, and then secondly, how to insert it into the eye. This is the standard scuba technique from Frank Price. I mean, almost everybody is doing a variation of this technique. You can see you run the spatula around, you get little tags, you've got to free it, and then you peel. Now, the early studies showed that the wastage rate due to tearing could be anywhere from 5% to 18%. Okay, and here you are, this is a small little hook. And now you peel. This is where you can tear. We now know that if the donor is 40 years or less, if the donor is diabetic, the chance of tearing is very high. And so today, people do DSAEK using donors which are less than 40 years old, and they try to avoid diabetics, okay, because of the tearing. And if you tear, you may not be able to use this tissue. So again, it's very primitive. You peel. You go around and you peel. So you go on and on. Having said that, I think if eye banks do it, they'll get better at it. So now the wastage rate is less. But if you do this in your OR and you tear it, you cancel the whole operation. Okay? So that goes on and on. Now, if you're doing this technique, which is still good, you notice he now has a different instrument. That was clear. That's the star chamber. And just now was a donor punch. So ASCRS have helped to develop a very nice donor punch block, which I will show you. That's the one. It's still prototype stage. It's transparent. This is a punch block and stripper all combined. So you can see it's transparent. This is using just the light microscope. And you can see it's just like a star chamber. You can see very well. You can peel. So if you like this technique, this is a nice block. Will it be disposable? Yeah, so it'll be disposable, single use. And you can see you can peel it very nicely. You can see very good visualization. So you don't have to change to a punch block and the star chamber. So this is the scuba technique. And you can see the peeling technique. So this will be, this is the Meta, my colleague, George Meta, and I helped to design this, and ASCRS has made this prototype for us. So I think this will make the donor peeling much better because you can have very good visualization. Okay? So I don't know when this will be available. Hopefully it will be available soon. ASCRS? Okay, so if you go to ASCRS, we should have this ready. Okay, so that's one innovation. So this is a paper which just shows that diabetic corneas, 15% failure rate in tearing. Non-diabetic, 2%. So 9 times higher risk. So again, we are limited. This is because of tears when you peel. All right, that's the problem. Frank Price shows the probability of tissue loss is 10 times higher in diabetics. If you go and ask your eye bank, how many patients who die and you get the corneas, what's the percentage of diabetes? It can be 10 to 20% in the eye banking population, okay? These are the tears. This is by Friedrich Kruse group to show that there are these peg-like interdigitations, Descemet onto basement membrane, and that's why it tears. It tears at these points. So how do we, here's another one where you see the horseshoe tears being described by Price's group, okay? 60% chance that if one tears, the mate will tear as well. So these are all the problems because you are peeling. So why don't we don't peel? So this is the other innovation we've demonstrated. This is a Dmx Tripper, which is now available. It's been available for some time. I call it the Dmx Tripper. It's not a peeler, it is a stripper. And it is a no-peel technique. This is in your wife's sewing kit. If you see this, when you want to cut thread, right? It has a blunt tip. This is blunt, and this is a sharp angle. So this goes into your thread, and it cuts here. So this is an unpicker, and we got the idea to develop one side of that instrument to go around to cut the Descemet. So that's the instrument. It's like a Y hook. This digs into the Descemet. These two tips are blunt. This is sharp. What about the other end? Now, all of you do DALK, and if you use the marginal dissector that we use, it's a blunt, it's shaped like a knuckle. You can see this is the DALK cannula. We've got something very similar at the other end. We just reverse it. Very simple. This is a lamella separator, a Descemet separator. So we now have an instrument with one end is here, the other end is there. So we first use the hooked end to go around, cut around, and then we reverse the instrument and we do lamella dissection, no peeling. So let's just see the video. So this is an easy strip. This is an older donor, maybe 60 years old. You can see that my hook has gone in, and what's happening, I'm leaving the instrument there. I'm just turning the cornea around, and it's cutting all the way around. You get less radial tears. Now, you can still get some tears, but generally, quite often it does this, and you see how nice it is afterwards. So you go all the way around. Once you reach the other end, see, I'm just pulling the donor around, and it's cutting at the Y angle. Can you see that? Very little radial tears. There's one tear there. That's the only tear. So I'm just going to move that tear away. You want to round that edge off. And you can see how nice the edge is. See that? And this is the lamella dissection. And I'm just lifting. Okay? No peeling. When you get to an area which is quite sticky, you just be a little bit slower and you can peel. You can do the entire dissection like this. Just go all the way around. Gentle lifting, separation. Now this is under low fluid. It means there is still some fluid, but not a lot. If there's a lot of fluid, it will tend to curl. Okay, then I'm using most of my Dmx are now 8 millimeters. So a gentle punch. So I stripped most of it, but I've left the inside, the last bit unstripped. Peel that away. And you can see that's the last bit I'm going to do. And that's it. Okay? So I do the whole thing without peeling. Here's a 36-year-old donor. And 36 is sticky. But even then, you're going to see the same thing. Now, the periphery is always a bit looser than the center. So it gets a bit more sticky towards the center. Just go around. You see a bit more resistance now, but just take your time, a little bit slower now. You can still dissect. Even if you tear, you have still control. You can just round it off like a buttonhole and do somewhere else, okay? So I've torn it once or twice. We've now done 44 cases consecutively. We've not lost any tissue. So no tissue loss. Okay, here is a bit more sticky. Just take your time, a little bit more time than peeling. Peeling is very fast. This is a bit more cautious, a bit safer. Any questions on this while we're showing this? So after this, I'm going to show you the other techniques.
How much of the center part do you?
Okay, how much the center do I leave? It depends. This one's very sticky, so I'm taking my time. Normally just a little bit, okay, because I don't want it to float off, okay? That's right, yeah. So there it is, right up. Anyway, it goes right to the end. There it is, okay? Completely free.
What staining is this?
This is Vision Blue. You can use Vision Blue or you can use membrane blue. Membrane blue is what the retina people use for vitrectomy, for membranes. That one is a deeper stain, okay? Yeah.
Can you use the idea of kind of like a little injection?
Yes. Yes, so what you're describing is injecting saline or air to blow up the Descemet. That was the original technique suggested. Agawa does that, Moraine does that. You can, but the problem is, as you know, when you inject air or BSS to separate Descemet like a big bubble, it only goes up to about 8 at the very most. So your donor is very small. You cannot go beyond 8. You can do that, but sometimes you get it, sometimes you don't. We prefer to do, this is more control, I think. Okay, so the advantage of our stripping technique, firstly, that hook, you just carousel around, you get less of these torn edges. But most important is that lamella dissection. You're no longer peeling. And you can be performed in young donors. I don't care whether they're young or diabetic. I can peel everything. I can peel everything. Okay, I can strip everything, not peel. And we're now looking at the cell loss studies. So we've done 44 cases so far. Okay, so that's peeling, but that's not too difficult. I think it's the surgery, how you put that donor in and how you unfold it, which is the problem. Okay. So why is DSAEK and DMEK so different? And why are the results so different? Because you're comparing different stages of evolution. Apples with oranges, okay? DSAEK is mature procedure. We've been doing it for 10 years over, 10, 15 years now, okay? Different improvements in technique. There are lots of inserters now. You have better results. The graft failure has gone down. Dislocation has gone down. The cell loss rate is getting better, okay? It's evolved. DMEK has not evolved. It's still at its first stage. It's still a tube you inject, whether it's glass or plastic. It's still scrolled up and you still have to use a BSS cannula and you tap, tap, tap. Okay? So it's like the original taco folding stage. It has not evolved. So that's why we need to change it. So how do we make it easier? How do we make DMEK less challenging, more consistent to perform? Well, you seek alternative surgical techniques to handle and control the donor. Do a different surgical technique. And maybe some more devices. I've just shown you for Dmx stripping, you have that device, it makes it a lot more controllable. Now, we have adopted DSAEK as our method of performing DMEK. All right? So in DSAEK, when we use the endoglide, a major advantage of this technique is enhanced donor control. Because it is the pull-through technique. You're actually holding the donor and pulling it in. And here, ASCRS has their DSAEK forceps, which also acts as a smile forceps. If you do smile, you use it to take out the lenticule. This holds onto the donor, and it is very good control. Okay? So, one level of control. Also, the AC is controlled because the endoglide, the chamber is controlled. For DMEK, you can perform DMEK like this. If you pull the donor in, if you can see here, I'm not pulling the whole donor in, I'm just pulling the Descemet in. And I'm holding on to Descemet. You have the same level of control, all right? Which means also that it cannot evert. It is always the right way up. So you don't have to put an S stamp or an F stamp or you don't have to mark or you don't have to have a slit beam. Why is it so difficult to handle DMEK tissue? There are three major challenges. If you touch it, you kill the endothelium, so you can't actually physically handle it. It always scrolls endothelium out, so you've got to unscroll it in the AC without touching it. And it wrinkles up as well. So why is it so difficult to handle compared to DSAEK? Well, it's obvious, right? There's no stroma. It's just pure Descemet, which wrinkles up like tissue paper. So, why don't we put back the stroma? If you support the stroma to support it, you prevent it from scrolling inside out, you prevent it from wrinkling, you can hold the stroma now. So when we first thought of this, we designed the Descemet mat. This is the stroma. We put the stroma back. It's a carrier, it's almost like a bandage contact lens, but tougher material. And we put the donor on, and now we have shape, we have form, it won't wrinkle. It adheres, you can hold it, you can wrinkle it, you can coil it, you can do what you like. So we started off a few years ago with this, and this is the mat, there's your Descemet, and we put it in the endoglide, just like normal DSAEK, and you can see we can coil it the right way up. Endothelium is inside, and here, the mat's left behind in the chamber, we're just pulling the Descemet in. The mat is still in the endoglide. See that? Control. That's it. That's the procedure. Okay? So we did some of this, and I did about 30 patients, mostly Fuchs, mostly combined with phaco and IOL. I had one graft failure, 3 rebubblings in the first 15 cases, First 10 cases, so none in the last 20. And we got reasonable vision, no rejection, but this is my learning curve. The first 15 cases, 60% cell loss, which is unacceptable. I got better. The next 15, we went down to about 42%. It's okay, but not that great, right? Endoglide, DSAEK for us, it's about 15 to 20%. So it's still double the cell loss. So they were okay, but not great. Then we thought, and there were problems with the mat as well, patent issues. So you've got to buy an instrument, you've got to have these mats made. Then we thought, let's make it even easier. We don't need a mat. We still have the stroma, the patient stroma, which we throw away, right? Unless you're using it for doubt. So let's use the stroma as a carrier, back again. It's all the way back to the original DSAEK procedure. And so this is my latest DMEK technique. I call it Hybrid-DMEK. I don't know what else to call it because it's DMEK, but it's a hybrid technique using DSAEK. Using a standard DSAEK surgical technique, it shortens the learning curve. If you're used to doing DSAEK, in this case with Endoglide, it's a bit easier to learn how to do DMEK. Important, this technique prevents the DMEK donor from scrolling, and therefore you do not need to unscroll. It reduces AC manipulation time. Potentially, we hope to have less endothelial cell loss. We don't need a mat anymore. We just need the stroma. So what do? We use the standard Endoglide DSAEK technique, which I've shown you. The only difference is that I pre-strip the Descemet first. Okay? So your tissue now is pre-cut tissue. So it's a DSAEK tissue which has been pre-cut. 100 microns, 120, doesn't matter. The only difference is I use the Dmx Tripper and separate the Descemet. So now your donor has got 3 layers. It's got your anterior cap, which you throw away. It's got your posterior stroma, which you're going to use as a carrier. And then it's got your final DMEK donor tissue, Descemet. 3 in 1. Same pull-through technique as the mat, but you just pull the Descemet in. Okay, so here, your DMEK stroma becomes the carrier, and you leave it behind. What are the advantages? You're still holding on to the donor. There's no chance of donor eversion. You do not need to have a slit beam or intraoperative OCT. You don't need to put a S-stamp. You get better control with the Endoglide because your chamber is intact, and it should lead to less cell loss. So let's have a look. Okay, so I'm just showing that this is pre-cut, yeah? You can see the cap. Okay, I do the same stripping technique. I'm going to skip because you've seen this already. This is the same as what you saw earlier. Okay, so I'm going to go back here. Okay, this is just the anterior cap. So now you have 3 layers, okay? I'm going to remove that anterior cap ring. That was the anterior cap, right? And you can see it's separated, but I lay it flat. Don't let it coil. I finish off the last bit. Put a bit of BSS just to straighten it there. You have to be very careful here. Don't put too much fluid in because it can float around. Okay, so this is my phaco. You can see this is quite hazy. I'm going to skip first. Okay, lens goes in. I do an 8 mm stripping. Lens is in, the pupil still dilated. This is under Helon. PI. This is, you can use the same DSAEK forceps, or we are now making a iris iridotomy forceps for the PI. I always do a PI. Every case of DMEK anybody does, you've got to do a PI. Okay, here we are. 3 layers going in now. Into the Endoglide. I remove the anterior cap. This looks just like DSAEK, except that the Descemet is loose. Just be a bit careful. That's the anterior cap. You still got your posterior stroma there. That's your carrier. You're going to use this to coil the endoglide. You need this stroma, otherwise it will just wrinkle up. Okay? And you can see that I'm wicking it in. This is the standard endoglide. Now, I put viscoelastic. I actually stopped because sometimes viscoelastic prevents the Descemet from opening up. Okay, in this video, I put viscoelastic. And then when you grip to coil it in with the forceps, you're going to hold both the Descemet and the stroma just to make sure. So this is the only time you're holding on to the tissue. And you can see and you can help to make sure it coils the right way. Just be a little bit careful, take your time. There. Okay, endothelium is in. So this looks exactly like DSAEK. Okay, you let go. We're almost running out of time. Is it okay to carry on a few more minutes? Okay. Okay, there it is. Now, same wound. This is a 4.5 millimeter sclerotunnel wound. The one I use for DSAEK, standard. You can see the AC maintainer. These are all Asian eyes. I think you do need an AC maintainer. AC maintainer has got very low flow. Okay, at this point, this is where you're going to go in and just reach in to pull the Descemet. So it can be a little bit tricky initially to find out the Descemet, where it is. You can pull the stroma in a little bit first, and then you can see. But you want to leave the stroma behind. This is your DSAEK forceps. And you can have a few attempts. If it's hidden, okay, I pull it out. That's the stroma. Now I reach below. And you have a few goes, but you should be able to eventually get the Descemet. There it is. Slight wiggle to loosen it. There it is. Slow, really slow. Take your time. AC maintainer is really off or very shallow here. Okay, now my wound is a bit tight in this video. Remove the endoglide chamber and the stroma goes out with it. Okay. There it is. There. See, this is real, not edited. This is how it is. You have to go this slow because you don't want to tear the Descemet. It's the right way up. Now you can do a bit of tapping, okay? Or you can put an air bubble in. Just wait. I'm holding on, it's the right way up. And I'm putting a bit of air now. There. That's about it. Okay, then you can move it across whatever you want. Okay? Essentially, that's it. That's the amount of manipulation. So it folded, unfolded correctly, everything looks fine. You can move it to one side if you want, but you're done, just about. Then you close the eye and do a full air fill, etc. Okay? Just go to the end there. Okay? Full air fill. Okay? That's what it looks like on day one. You know you've done well when it's this clear. Okay? This patient ends up at 1 month with 20/20, 15% cell loss. You can tell because there's almost no manipulation. All right? That's a cell count there. We've done another 13 cases. Okay. Here's a more difficult. You know, people show nice videos. You should show difficult ones as well. It's not so simple. Here everything looks fine. I'm just going to skip this through here. All this is the same. No difference. Here we go. In. Everything looks the same as just now. Same thing. You're going to go in and reach in. There it is. Nice and loose, this one. Okay, pull it almost all the way out. And then you pull out the... Now, I'm afraid of losing the chamber here. You see that the cornea will buckle, so I really have a very flat chamber. So I've told my assistant to just increase the AC maintainer just a little bit. And this is what happens. Okay, you can see it's buckling. So I said, okay, I told my nurse, increase the AC a bit. See, it's flat. And she increases the AC maintainer. Oh. Disaster, right? You don't know where it is. Don't worry. Just be patient. You can move around, but it's still holding it the right way. You just tap. Even now, I don't know which way's up. But because you're holding on, it cannot be upside down. You will tell. So this is also unedited. Okay, just keep going. Just tap away, whatever you want. And even though it hasn't, I can't quite figure it out there. Okay, it's because you're holding on. Okay, so even though it's all scrunched up in one corner, because you're holding on, you can rescue these cases. Here we're using the air bubble just to open it up. Quick tip, this air bubble's too small yet for me to let go because it hasn't unfolded. A slightly larger air bubble, so it will unfold. Okay, so that's it. Full air fill. There. Okay, so you've seen this? Yeah, hyphema, yeah. It's okay, I did a full end tamponade, the blood is below. Okay? Be careful of hyphema. That's another story, okay? Be careful of fibrin, be careful of hyphema. So, my DMEK, I started off with the DMAT. The MAT, I did the first 15 cases. Not very good results. 59% cell loss, 1 primary failure, 3 rebubblings. My next 15 cases, I got better. 40% cell loss, no failures, no rebubbling. And now, you've done 14 cases now with the out the mat. This is the Hybrid-DMEK procedure. We're down to 28% cell loss on average. So we have some which are 15%, some which are 35, 40%. Okay, but overall so far it's about 28% cell loss, no primary failure, no rebubbling. Now these are still small numbers and we're still learning. I'm still learning the technique. But I actually think that we've been able to reduce the cell loss rates. And now we have a procedure which is a little bit more reproducible. So in summary then, DMEK is the new EK. Very sexy. We all want to do it. Okay, but it's very difficult still. Needs to evolve. It needs to change. One way is to make DMEK more like DSAEK. So we've already mastered some of those skills, and my technique uses what I'm used to, which is my inserter. You can probably do this technique maybe with the Busin or with the endoserter. I'm not sure. But the same principle of holding onto the donor. I just use the endoglide. It gives me more control. And use your posterior stromal lenticule to control prevented scrolling. My early results seem pretty good. So my suggestion is please don't scroll. Okay, thank you. That's all my colleagues. And invite you to Seoul, Korea for the Asia Cornea Society meeting in December. And World Cornea Congress, first time outside the US, it will be in Singapore in 2020. Thanks. Any questions?
Just want to ask,
Yeah.
when you pull in,
Yeah, when I pull it in.
endothelium is inside.
Yes.
Okay, still holding on.
Yeah.
So if you want to attach it to the
Yeah.
stroma,
Yeah.
still the endothelium is facing the endothelium. How
No. The endoglide, what happens is when we load it, endothelium is up. When we take it out, we have to turn it the other way around. So when we insert it, it's in the anatomical, so the coil is like this. Yeah? So when you pull it in, it opens up like that, endothelium down. So what you don't see is that once you load it upside down, endothelium up. Once you take it out, you have to turn it the right way and then insert it. Very critical. Any questions? Okay? Thank you very much.